Welcome to the video tutorial on CLL by Synapse. This is the fourth video in the continuation of the blood malignancy series. So as I said, we're going to discuss about CLL today. So CLL is called chronic lymphocytic leukemia bar lymphoma. Right? So we have done this many number of times. Let's do it again. So chronic refers to the mature cells of the lymphoid series, and mind you, it is cytic. Most of the previous malignancies we have studied would be saying blastic because they're immature cells. Because these are mature cells, it's lymphocytic. So this refers to the series. So basically the lymphoid series. And I'm told leukemia means problem is in the neoplastic cells or in the bone marrow and getting into blood. But lymphoma refers to the aggregation or basically the proliferation of the neoplastic cells in the lymph nodes or specific organs and forming a mass like this. Okay, so hence CLL could present as leukemia or lymphoma. Now, if it is presenting as lymphoma, it is commonly called SLL. Okay, SLL is small cell lymphoma. Okay, again small because these are mature cells. So we have studied in the lymphoid series. We go from the blasts. Okay, let's just write it off here then. So we've studied about the blasts, lymphoblasts. So there were like group of 3 cells which we merged and called them as lymphoblasts. We have the multipotent hematopoietic stem cells which transform into the pro-B cell. Then we have the pre-B cell, and then we go into the blood and there'll be the mature B cells. Then 95% of them go to the germinal center of the lymph node and 5% will go to the mantle zone. And here they will mature to be either plasma cells or they'll become memory B cell. Memory B cell. Okay, so this is what we had studied. So these 3 cells were collectively called as a lymphoblast. Now these blasts are big in size, right? So they are really big and they are mature cells. So they're going to, the nucleus is so big that it takes up the whole cytoplasm. So this will be your kind of granular cytoplasm. This is a lymphoblast. Okay, in the first lecture we had seen myeloblast, lymphoblast difference. Now as this cell goes down this lineage, goes on maturing, so it will become a small cell. Okay, a small functioning lymphocyte. Okay, now if you see the size of this is small. So since it's mature cell, they are called a small cell lymphoma. Again, lymphoma because here we are going to study about the aggregates, okay, of the cells in a particular organ or lymph node. Okay, fine. So let's move ahead. I'll just add some more points onto this chart because we need to remember some surface markers. So let me just clear this and put some CD markers on this chart because it's pretty important. Okay, so this stem cell is CD34 positive. Okay, CD34 positive. This is quite important to remember. Next we go to Pro-B. So what does Pro-B do? It will retain this and it will get a pan B cell marker that is CD19 along with CD79. Okay, so what are the 2 additions here? We need to remember CD19 and CD79. This is pan B cell marker, very important. Next, okay, what we'll do is we'll drop off CD34 because the cell is getting matured, right? So this is the precursor marker basically. So now CD34 is gone. Instead, we have CD19 remains because it's pan B, so all B cells will have it. Once acquired, it will remain. CD79A, okay. Then you will have CD10 and TDT. What is TDT? It is trinucleotide transferase. Okay, trinucleotide transferase. Okay, so once again CD34, then Pro B has CD34 with CD19 and CD79A. Then pre B cell will have extra two more and loses 34 basically. So CD34 is gone. Instead, you will have CD19, 79A, CD10, and TDT. Then we need to study what exactly happens to the mature B cell. Correct? Because CLL is all about mature B cell. So what are the mature B cell markers? Okay, go with me. CD19, CD79A. Now what happens? You have to add some more here. CD20. So if you just know numbers, CD21, CD22. Okay, simple. So 19 was there, add 20, 21, 22. Okay, and these two will remain. Fine. Again, we'll get rid of these two, right? Okay, they're just markers of pre-B cell. Now we have heard that B cell receptors, in immunology we have read that the immunoglobulins are present. So they form as the B cell receptors, okay, the antigens. So now that's why we have surface immunoglobulins. Okay, we have IgM and IgD. Okay, so these will indicate the presence of, the maturity of the B cell. Okay, fine. So this is very, very, very important. Okay, so since CLL is tumor or neoplastic growth of the mature lymphocytes, so these markers are very important. So let's move ahead. So age group, correct? So age group here, it is more than 65 years. Okay, so old people, and median age is around 72 years. Then sex predilection, again more males are more than females. So other blood malignancy, we have studied the risk factors, environmental risk factors and hematological risk factors. Luckily, there are none for CLL. Okay. So now we will look into how the patient will present. Right? So clinical features. So again, to understand the clinical features, if you just know what is happening in this tumor, it is very, very simple. So we said it is chronic, that is basically mature cells. So mature cells spill into the circulation more than in the marrow. So you won't have the feature of pancytopenia, correct? So these mature cells will link. So that's why you're going to have lymphocytosis. First is lymphocytosis. Okay, so you'll have cells like absolute lymphocyte count is going to be more than 5,000 cells per microliter. Okay, now lymphocytosis, will it have any clinical feature? Will the patient have any symptom? Usually not. So hence the most common clinical presentation is asymptomatic. Okay, now again, let's all of the clinical features just depend on this one. Okay, so mature cells, so they're going to produce cytokines, so they will have B symptoms. So around 30% of these patients will have B symptoms. Next, again, we have studied that a variant of CLL, which basically comes as lymphoma, is called SLL. So what is lymphoma? Lymphoma is neoplastic cells forming aggregates. So that will result in lymphadenopathy. And or splenomegaly. Okay, So these two are important. So these are the clinical features or clinical presentation of CLL. Now, okay, the patient has presented. What shall we do? We'll have to go and diagnose this patient. Okay, so we have studied that diagnosis. First, we have to study the morphology, correct? We have to do the morphology. Okay, sorry, yeah, we have to do the morphology first. So we will use the peripheral smear. What do we see here? So we've characteristically been learning about something called as the smudge cells. So if you're going to prepare the slide here, okay, if you use a drop of blood and prepare the smear and you see observe under the microscope or see under the microscope, what happens, these cells, the tumor cells, like they're kind of fragile, right? So they'll just break up, okay? So, and hence that area, instead of seeing a normal cell, that area gets smudged because the cell is broken down, okay? So those are called as your smudge cells. Next, we will do the immunophenotyping. Very simple, this is correct, because it will give you exactly what is the tumor about, right? Is it the lymphocytes? Is it the myeloblasts? Okay, that's what we've seen. So the cell markers for mature B cell were quick 19, 79A, 20, 21, 22, surface IgM and IgD. Okay, fine. Right. So, in other tumors, we have studied a lot about molecular genetics actually, but here only one thing to remember. Only one thing. That would be 13q deletion. Okay, 13 everyone considers a bad number, but for CLL, 13 is a good number. You see, 13q deletion is having good prognosis. Rest of the other mutations or translocation are associated with bad prognosis. 13q deletion is good. Okay, fine. Now, one important clinical feature that may be associated with CLL is autoimmune hemolytic anemia. Okay, a patient with CLL coming with anemia. Okay, sudden onset and hemoglobin dropping to lower levels, very quick drop in HB, that should arise the suspicion of autoimmune hemolytic anemia. So they'll have warm antibodies. Basically, it is IgG. Okay, so keep this thing in mind. This is important. Fine. So now we have diagnosed. Okay, what do we do now? We need to treat the patient. Correct. Treatment of CLL. Okay. See, the patient we have told is already more than 65 years. Okay. And if you're treating any tumor, we're again going to give anti-cancer, basically the anti-cancer drugs, anti-metabolites. Okay. So these drugs are more toxic than the tumor itself actually saying. So there are indications to start the treatment on CLL. So basically, not all patients on CLL will receive treatment. Okay. So what are the indications then? Okay, so the patient is very distressed. Okay, he has a lot of B symptoms. Okay, so you need to relieve that. So we will start him on treatment, and then CLL is that it is very mild. Okay, as in it's not a severe form of a disease, right? So if it becomes severe, that means there will be marrow infiltration and will cause marrow failure. Okay, so that means we need to start the patient on treatment. Then presence of autoimmune hemolytic anemia, which we just studied, right? Okay, and if there is lymphadenopathy and splenomegaly, increasing lymphadenopathy and splenomegaly. So these are the indications for treatment. Okay, So what will you treat the patient with? Okay, so the again the mnemonic here would be FCR. F for fludarabine, C for chlorambucil, R for rituximab. So this is CD20 inhibitor, anti-CD20 drug. Okay, so one new drug that is just to be mentioned here will be alemtuzumab. Okay, alemtuzumab. So basically, you have to remember only three drugs, that is FCR, fludarabine, chlorambucil, and rituximab. Okay, so that's the treatment. So not everybody gets a treatment. If there are the above mentioned indications, only then we will start. Okay, because the drug itself will produce more side effects. Okay, so the person is already 65, we'll just let him live. Okay, yeah, because CLL is mild, it's not that bad a disease. Okay, now just quick mention about SLL. Just told it's the lymphoma counterpart of CLL, which is called SLL. Now, SLL is a low grade lymphoma. So, low grade lymphoma. So, lymphomas are categorized as low grade, intermediate grade, and high grade. Now, SLL is low grade. If you see a low grade lymphoma transforming into a high grade lymphoma or into Hodgkin lymphoma, then this is called Richter syndrome. Okay, Richter syndrome. Okay, we need to be really careful about this because SLL and CLL are like really good diseases, right? So they're just not so bad. They behave well. Okay, and then if it is transforming into a high grade lymphoma, okay, so then we need to be careful. So what are the features that are suggestive of this transformation? So it could be like, right, cancer. So we'll have weight loss, then we will have cachexia, then fever, okay, and lymph node involvement, right? More number of lymph nodes are involved, and there will be rapid increase in their size also. Okay, so these are the features suggestive of Richter syndrome. Now, if we look at the staging, okay, this is pretty easy to remember also. So, Rye and Bennett staging for SLL. Okay, so first, okay, we start with stage 0, 1, 2, 3, and 4. 0 is just there is lymphocytosis. So it's just increase. We have read that absolute lymphocyte count will increase more than 5,000 per microliter. So that's the first stage. It is just simple lymphocytosis. Now we have next is lymphocytosis with lymphadenopathy. Okay. Next, 2 is lymphocytosis with lymphadenopathy with splenomegaly. Okay, 3 is this with this with this and anemia. Stage 4 is all of this plus anemia plus thrombocytopenia, basically decreased platelets. Okay, so that is the classification or staging of SLL. Okay, so and lastly, just to remember that I've mentioned 13q deletion is really good. Okay, it's associated with a good prognosis. Okay, so that's all you need to know about CLL and SLL. What did we learn? Okay, we know that they're mature cells. Okay, so mature cells are in the blood. Okay, and they go and settle in lymph nodes and in organs, so hence producing lymphadenopathy and splenomegaly, which is a feature of CLL bar SLL. So presentation, just remember an old aged male, okay, above 65 years, Okay, they're most commonly asymptomatic because they have lymphocytosis. If they become symptomatic, they can present to you with lymphadenopathy, splenomegaly, or the B symptoms, and there could be associated autoimmune hemolytic anemia in these patients that is to be suspected when hemoglobin drop is rapid. And the molecular genetics, 13q deletion is really good. Okay, peripheral smear, you see smudge cells, and immunophenotyping important CD markers are CD19, 20, 21, 22, 79A, and surface IgM and IgD. Okay, then once the diagnosis is made, you have to weigh whether treating this patient is a good option, or to just let it be. Okay, because of the side effect of the drugs. Now, indications for treatment, we have seen that if there is lymphadenopathy, splenomegaly, and patient is having excessive of B symptoms and presence of AIHA, under these conditions, we have to start them on treatment. So, what are the drugs? The mnemonic is FCR: fludarabine, chlorambucil, rituximab. Rituximab is anti-CD20 molecule, drug, and then is SLL staging. Okay, Rye and Bennett staging. And just bear in mind what is Richter syndrome. It is a low-grade lymphoma which will transform into high-grade lymphoma. Features will include weight loss, cachexia, fever, sudden increase in the lymph node size, and increased number of lymph node involvement. Okay, so that's it about CLL, SLL. See you in the next video.